Hi, everybody. Thank you so much for joining us. I am Dr. Ellie Stein, and this is a very special webinar featuring Dr. Juliana Corlier, and she's talking about her groundbreaking research, not yet published, so we're very privileged to be able to hear about it, on repetitive transcranial magnetic stimulation in people with depression, fibromyalgia, and ME/CFS. Now, probably most of you have heard of rTMS, and that's why you've tuned in because you want to learn more about it. It's been around for at least, we'll say 20 plus years, but it's only been approved for treatment a little bit more recently. It's approved in Canada, the US, and Europe for a number of psychiatric conditions. It's gaining in popularity because it's non-invasive, it's effective, and the side effect profile is pretty favorable. So it's approved for things like major depression, obsessive compulsive disorder, migraine headache, and believe it or not, even smoking cessation. I just learned that in the last couple of days in preparing for this. But it's under study for many other conditions, including the ones Dr. Corlier is going to talk about today, chronic pain in particular, and also ME/CFS. I just want to give a little anecdote from my clinical practice. So in Canada, rTMS has been, we'll say, limited availability until recently. There's now private clinics popping up, and the public clinics at the hospitals are now kind of expanding, and it's getting easier and easier to access. So in the last few years of my practice, knowing that it was available and knowing that I had many patients that weren't able to tolerate other forms of depression treatment, I referred several patients for rTMS. And even though it's a hard treatment for someone with low energy, because you have to go for a bunch of appointments, nevertheless, it was tolerated by everybody. Virtually everybody benefited to some degree. And one of the symptoms, in addition to their depression getting better, that many people mentioned was increased energy. And so that was a few years ago because I've been retired now for 2.5 years. But I have lots of questions in the back of my mind about what are the possible off-label uses for rTMS. So when this opportunity arose for Dr. Corlier to share her expertise with us, I jumped at the opportunity. I just want to introduce Dr. Corlier. She's an assistant professor and she's the assistant director of research at the Neuromodulation Division, Department of Psychiatry at the School of Medicine at UCLA. Now, what impressed me personally most about her CV is that she has attended higher education in 3 languages, German, French, and English. As someone who struggles to learn languages, that's extremely impressive to me. Her goal is also really relevant to our community of people who have complex chronic diseases because she's trying to refine the protocols and figure out how to individualize them to specific disorders, but also to individual people. And she's expanding the scope of rTMS to include things like chronic pain and fibromyalgia. I also noted in kind of researching her that she did a study a couple years ago on insomnia. And so I'm hoping she can add a few words about that, because of course that plagues our community. And just a heads up that the director of the rTMS program at UCLA is Dr. Andrew Luchter. He's Dr. Corlier's colleague, and he has agreed to be a guest on my podcast, the Dr. Eleanor Stein podcast. I'm going to interview him next week, and we're hoping to publish that podcast episode on July 4th. So just to say, this is kind of a two-part with Dr. Corlier presenting some of the background and research information, and then potentially Dr. Luchter expanding that into some of the newer uses and the clinical uses. So, with that being said, Dr. Corlier, thank you so much for agreeing to talk to us, and it's all yours.
Ellie, thank you so much for this kind introduction, and the pleasure is all mine. Thank you for having me here. I am delighted to have this opportunity to tell this audience about our work and, hopefully share exciting findings that you will also find exciting. I do hope so.
So I'm going to
Um,
mute myself and I'll just come back on towards the end.
of course. I have no disclosures. And just before I start, I wanted to, go over the learning goals for today. I would obviously like to tell you about the technique itself. What is transcranial magnetic stimulation, or TMS? How it can be used for the treatment of depression and chronic pain, but also how it can be personalized and individualized for conditions that are a little bit more delicate, such as ME, CFS, or other conditions. My talk will be organized in 4 parts. First, a few words about the technique, then TMS for depression, which has been the very first FDA indication for TMS, then our work on fibromyalgia and chronic pain, and I will close with our research on TMS for ME/CFS. So let's dive right in. What is TMS? TMS is a non-invasive brain stimulation technique to modulate brain activity. Now, give me a second to move around my screen here a little bit. This is what it looks like. You see the chair with this cart next to it. There are 3 major components. Number 1, this box here is the electric pulse generator, that is also called the stimulator. Number 2, here in black, that's the magnetic coil that actually goes on top or above the brain. And the number 3 is, the cooling unit, which is an essential piece of equipment because it prevents the whole system from overheating. Now, it is a very powerful and in some ways intimidating piece of hardware. And I wanted to, demystify the technique a little bit and just to give you a better grasp of what it actually does, without boring you with the physics of it. Think of a wireless phone charging device. Many of you might have such a device at home. You plug it in, it's usually a circular base, and just by placing your phone on top of it, without a wired connection, your phone is magically being recharged. Now, what is happening behind the scenes is actually the same principle that is also used in TMS. So let me debunk this here for a few minutes. The basic underlying mechanism is that you have the base, the charging base here on the bottom, and then also called the transmitter coil, and then your phone, the receiver coil. Now, if this base is plugged in, there is electric current flowing in circles. And if that happens, following Faraday's law, the current flowing in a circular direction, that will generate a electromagnetic field visible here in these light blue circles. Now, if that happens, the electrons that are trapped inside the phone are actually sensing that magnetic field. They start to flow inside the circles. And that flow of electrons powers your phone. Now, let's translate that analogy to TMS. In TMS, we're talking about transcranial, trans through, and cranial, the cranium, the skull. Same approach, right? We place the coil under one on the head. The electric current, you see the coil is shaped also, it has 2 circles. The current flows in the circular direction, and that will create this perpendicular electromagnetic field that you see here in like the dark blue dashed lines. And that magnetic field penetrates the skull, so transcranial, right? And in the brain, that current actually activates or depolarizes neurons that are located right under the focal point of the coil. And in that location, if a lot of neurons are activated in a synchronized manner over time with repeated session, this, we assume, will lead to enhanced neuroplasticity. That means that the synaptic signaling will be improved or optimized. There might be excitatory neurotransmitters like these molecules in purple that will be increased in quantity, or there will be new ion channels popping up in the synapse. And that is the assumed mechanism of function of TMS, neuroplasticity. Now, FDA indications do exist for treatment-resistant depression, obsessive compulsive disorder. Since a few years ago, I think since 2020, roughly, smoking cessation, and actually what many people do not know, there is a particular protocol also effective for migraines. Now, it is a relatively low-risk procedure. If you think and compare it to electroconvulsive therapy or even medication, there is no electroshocks, right? It's not that you need anesthesia. It's not that you feel like the electroshocking sensation. It doesn't even have to be painful. Some patients just sit in the chair and they can watch TV, be on their phone, listen to music. So it's a very non-invasive technique. And the side effects, of which there are some, they're pretty, relatively easily manageable. The most frequent, I would say, is the report of headaches, muscle contraction, and sometimes facial pain. If we stimulate the facial nerves, you can have some burning of these facial nerves. Now, this is relatively easily manageable by just turning the coil or slightly shifting the coil, within a few millimeters. And then some other side effects like lightheadedness or feeling wired or even a little anxious can be easily taken into consideration by adjusting the intensity. So that's usually a sign of overstimulating. So if we reduce the intensity of stimulation, that usually also goes away. Now, the most serious side effect is a seizure and possibly also a generalized seizure, thinking, epilepsy seizure. Now, usually the seizure stops right away once you remove the coil, stop the stimulation, seizure stops. But even then, we can make sure that seizures don't occur. And actually, seizures is a very rare occurrence across all TMS clinics, and that is because of that keyword I write motor threshold, because every single patient will receive their individual dose or stimulation intensity of TMS. And we do that by figuring out how much energy your brain needs to see a finger movement in your hand, right? So we test different levels, and once we see the slightest motion, we stop intensity right there, and that's, we think, is the just right dose for you. And by doing so, we can make sure that seizures generally don't occur. So good side effect profile. Now, not all TMS is the same. There are different stimulation protocols. For example, the major parameter that you can change is the frequency in which these electromagnetic pulses are administered. So the very first protocol that was FDA approved is called the 10 Hertz TMS. 10 Hertz means that there are 10 pulses per second that are being sent to the brain. So you have to imagine tap, 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 and so on, right? The other very common protocol is called intermittent theta burst stimulation, and it is a patterned form of stimulation. Sounds something like that. Brr, brr, brr. So you get the idea. There is like bursts of stimulation, pauses, bursts, and pauses in an intermittent kind of pattern. These two techniques are the most frequent ones, and both are FDA approved. Now, there are also different targets on the brain for stimulation. For example, the left dorsolateral prefrontal cortex, usually the classical site for depression, the orbitofrontal cortex, that's a common treatment for OCD, obsessive compulsive disorder, and motor cortex used for pain stimulation, for pain treatment. I will talk about this a little bit more in detail later. There are also different coils TMS coils. The classical is the figure of 8 coil, but more recently, there is also a new coil called the deep coil, deep TMS, that is supposedly has a deeper penetration in the brain and is used, for example, for OCD, but also smoking cessation. So the FDA-approved protocol for smoking cessation uses such a deep TMS coil. Now, administratively, Dr. Stein mentioned that a little bit in her introduction. It has been previously, even a few years ago, the case that TMS has been primarily been offered at academic medical centers. However, now more and more we see clinical practices popping up everywhere in Southern California, where I am based. We have, I couldn't even get a count of how many practices there are. A lot of clinics, TMS clinics. And, there is, most insurances in California do reimburse TMS treatment. However, primarily for depression. So off-label treatment or other conditions, not so much. Even OCD and smoking cessation is still in the developing stages. And it is not the first line of treatment. So by being eligible, I mean that usually the insurances want to see that the patient has failed any kind of medication, at least 2 different agents, and also psychotherapy. And only then they become eligible for insurance reimbursed TMS treatment. But we see increasing numbers of patients receiving insurance coverage. So to sum up that first section, TMS, think wireless phone charging. As an analogy, we do think that the mechanism of action of this treatment approach is the enhancement of neuroplasticity. It is an FDA-approved technique. It has, for a number of conditions, depression, OCD, smoking cessation, migraines, with a relatively low risk profile. And there are different stimulation protocols and brain regions, so a large parameter space that we can further explore and individualize for other conditions. Now, moving on, TMS for depression. As I mentioned, depression was the very first condition that has obtained FDA indication for TMS in 2008. So over 15 years ago, quite a while ago, the approved treatment is using the left dorsolateral prefrontal cortex. And again, the FDA treatment course is classically considered 30 daily sessions is the main course, 1 session a day for 6 weeks, and then 6, let's say, phase out or maintenance sessions, like 1 session a week for 6 weeks. That's the classical protocol. And, you have to think these are the most treatment-resistant patients that we see. They didn't respond to medication or to therapy. So of those treatment-resistant patients, we do get 35 to 50%, depending on the center, depending on the study, percent of response. So it's a pretty astounding response rate. And as I mentioned, both protocols, the 10 hertz as well as the ITBS, intermittent theta burst, are non-inferior to each other and are pretty, you can see here on my graph, the red is the 10 hertz treatment, the blue graph is the ITBS, and they really track each other in efficacy throughout the course of 5 weeks, and then treatment ends 6 weeks, and then follow-up session. Now, the advantage of ITBS, it is shorter. However, 10 hertz might be a little bit less harsh, or at least subjectively be better perceived. Now, new developments in the TMS. So we had the first indication of over 15 years ago. What has happened in the field for depression since then? Now we have a novel protocol called SAINT, Stanford Intelligent Accelerated Neuromodulation Therapy. It is primarily at its core, or the whole point is to accelerate the improvement in depression. So you have to, it is an FDA cleared approach. You have to think it's a TMS retreat, right? Rather than waiting for 6 weeks daily visits. Here we condense the whole course into 5 days. Every day, so here you see day 1, 2, 3, 4, 5. Every day you get 10 sessions of TMS. So it's really session, 15-minute break, session, 15-minute break. So you spend the whole day in the clinic with some intervals of rest over 5 days. It's a pretty intense approach, right? You get the ITBS, that accelerated or shorter form of ITBS, and there is some secret sauce to it. I will not go too much into detail, but the targeting of the exact location within the left DLPFC, it's a pretty large region, is based on magnetic resonance imaging scan. So you need to go into the scanner first, get the image, get your exact coordinates, and then use these specific individualized coordinates. Now, with that technique, different studies report 70 to 90% of response rate. So that's pretty impressive. What we do not yet know, and is still awaiting confirmation in independent replication studies, is the durability effect. Is it just as durable as standard course of TMS for depression, which can be, several months for up to several years in some cases, right? So here the jury is still out there for durability of SAINT, but very promising. Now, in other news, there are also approaches seeking to augment the neuroplasticity aspect of TMS. As I mentioned, this mechanism of action, assumed mechanism of action, is the boost of neuroplasticity. And so a couple of researcher groups came up to give a concomitant drug called D-cycloserine, a very low dose, 100 milligrams, and it is acting as an NMDA receptor agonist. So NMDA receptor here, light gray, we think that it is involved in mediating these TMS-based clinical benefits. So if we give an agonist for this channel, we think that the neuronal firing will be further boosted, further synchronized, and more connections between neurons will be formed over time. In this study, they had it was a randomized study with a placebo-controlled, and you see that the group that has received both ITBS plus the D-cycloserine had actually a stronger reduction in symptoms than did the placebo group, and that was true, for 2 weeks and also 4 weeks post-treatment. So, there might be future work coming in that direction. And so with this approach, we are also, from the 35 to 50% of response that we see in conventional treatment, we can get up to 74% or so, even with the regular course of treatment. So very encouraging. Now, to sum up the section for depression, I will say, lots of different protocols. ITBS and 10 Hertz are the two major protocols for depression. They're not non-inferior to each other. There is the SAINT accelerated protocol that wants to get you better even faster with very good outcomes, as well as the idea of boosting plasticity with pharmacological agents and enhance TMS outcomes in that way. So that's the news on the depression front. Now, switching gears a little bit to fibromyalgia and your chronic pain. This audience is probably even more familiar with this than I am. Chronic fatigue, chronic pain and depression are highly comorbid. And not only comorbid, they're also interdependent bidirectionally. One can precede the other and vice versa. And there has been even an increasing number of studies showing how there are shared pathophysiological mechanisms between depression and chronic pain and fibromyalgia, and also overlapping brain networks that are dysregulated. So it is not surprising that in our own clinic, when we on a regular basis ask all of our patients who seek treatment for depression, we also ask them how are you feeling? How is your pain on a scale between 1 and 10? We were actually well, surprised and not at the same time. We were surprised about the number. Over 2/3 of our patients reported moderate to severe pain, and that irrespective whether they had a formal chronic pain diagnosis or not. So majority of patients just carries chronic pain, with them in their daily life. And a lot of the larger group of these patients experience something like whole body pain, think fibromyalgia. And importantly, the patients who did present with pain symptoms, they also had usually more severe depression levels before treatment, even when coming to the clinic before the start of TMS. So this is now really the driver of a lot of our research, and that is the TMS response in depression in that group of 160 something subject. If the group that said, we do not have pain on a daily basis, they had a response in depression to TMS of, around 40%. Now, the patients who said, I do have moderate pain or severe pain, their likelihood to respond in depression was actually much reduced to 22 or even 12%. So from that, we really kind of learned that the TMS outcome in depression is dependent on the presence of pain. And that was really kind of, eye-opening to us, because then we were thinking, wow, how about an integrated treatment approach where we not just treat depression, but also can hopefully offer something for pain treatment, and maybe there is some kind of synergy between the two, think overlapping networks, shared mechanism of depression and pain, fibromyalgia, so we can get them better more in both depression and pain. So that was really the motivating factor for us. So we started looking existing literature, what have people done in the field of TMS and fibromyalgia? And we were, surprised to see that, actually the left DLPFC, same target as for depression, has also been used in some pilot studies for fibromyalgia. There has been shown some possible analgesic effect, even though not super conclusive, improvement in quality of life and also fatigue. Here I show a review analysis by Sun et al. That show a number of different studies and the outcomes. Now, for pain, some studies did show an improvement in analgesic effects. Some did not, and so we were not quite satisfied with that DLPFC target alone. We started digging deeper for other targets, and we found another target, the primary motor cortex, also called the M1, that turned out to be the most effective target for pain. And that included very robust efficacy for neuropathic pain, so nerve damage in the periphery, but also central pain like post-stroke pain, but also headaches and migraines. Now, the motor cortex is not an intuitive region of the brain that you would associate with pain reduction. You would maybe think, sensory cortex or the insula that codes the proprioception, or maybe the cingulate cortex that is responsible with coding of salience of stimuli. But actually, it turned out when we started looking into the mechanism, the motor cortex, here is schematically represented in blue, has a lot of downstream connection on the premotor cortex and also prefrontal cortex that might explain this top-down influence. So with that in mind, we, just as a pilot study, open label, kind of naturalistic setting, we wanted to see how about we do a comparison. Group 1, we have depression patients only. They do not have significant levels of pain, and so they receive just the prefrontal cortex stimulation. Treatment as usual. The other group, more severely ill, has depression, but also chronic pain. We know that they are at baseline more ill, but also have worse outcomes. How about we give to those patients not only the prefrontal cortex stimulation, but also the motor cortex? And can we get them better to the same level as group 1, right? So bring them closer together. Now, that's what we did. So naturalistic comparison, this was not blinded, this was not prospectively assigned or randomized. We had these two groups. Single target was the about 200 patients with depression only, and female to male patient ratio was roughly the same. The second group, the dual target group, was comorbid group, right? Depression plus pain, those who usually have worse outcomes. And we confirmed that this comorbid group is, primarily female, to almost 3/4 female. So females are more affected by this comorbidity, unfortunately. And so we also confirmed that the comorbid group here in orange was at baseline more ill, significantly more ill than the non-comorbid group. And so they received, one treatment site versus two treatment sites, and that's what we found. Group 1 had around 40% responders. Group 2, over 50% of responders. We were so happy to see it. And then this is the histogram showing the breakdown for individual patients. On average, group 1 improved by 37% and group 2 by 47%. So not only were we able to bring group 1 into closer, group 2 actually exceeded the response rates of the classical treatment group. So we were so encouraged by that and so enthusiastic that we are actually now currently conducting a randomized double-blind trial, zooming in only on the comorbid people, right? Because those are the patients who need better care, in our opinion. So we're looking only comorbid conditions. We're prospectively assigning them into condition A or condition B. Condition A are both targets active, DLPFC plus M1. Condition B, the M1 target is placebo-controlled. And so they receive the classic protocol of 30 daily sessions. And in addition to that, we're also examining neuroimaging and electro-EEG, electroencephalography. That is, we're measuring brain activity, electric brain activity, to see how is the response in the brain different from one set of treatments to the other. So do the different conditions vary not only in response rates, but also physiologically. And we're also collecting blood samples, and we have some interest to look into changes of inflammation in these patients. So to sum up that section, TMS for fibromyalgia, chronic pain, it is very comorbid with depression, at least in our clinic. Those patients who have pain are more severely ill, have usually worse outcomes. We had this open label, very encouraging evidence for DLPFC plus M1 stimulation sites, maybe some synergistic effects. So we're conducting this prospective trial, and hopefully we will confirm our observations in the future. Now, in my last part of the talk, I would like to present some work on ME/CFS, myalgic encephalomyelitis chronic fatigue syndrome. In this audience, probably I do not need to emphasize that this is an extremely severe condition and really debilitating, like I have to do in some other, to some other audiences. This is not even a rare disease, like many would think. So many individuals suffer from that. Obviously, the hallmark is extreme fatigue, even after minor activity that is not refreshed. Your energy is not refreshed after rest, but it can also be accompanied by sensory sensitivity, brain fog, chronic pain, and other conditions, very, very hard to live with condition. So because of, there is not a lot of work, TMS work for ME/CFS, we started thinking, where should we begin? And obviously, we did not want to reinvent the wheel, and used our existing studies in other conditions to extrapolate the protocol, just a place to start for this group. So we know from the slides that I'd show you, prefrontal stimulation works for mood and fatigue. That is pretty established. Now, we also show that this interesting target of motor cortex, works for pain. We have also, after looking more specifically for fatigue literature and TMS, we found that there's actually quite a bit of TMS work in sports sciences. And that is particular research conducted on healthy controls where they use TMS to assess neuromuscular fatigue and its mechanism, but also use TMS to reduce central fatigue and the subjectively perceived sense of effort in athletes. Now, clinically, TMS can be used to reduce fatigue in multiple sclerosis. So it turned out that this motor cortex target is actually pretty effective, not just for pain, but fatigue as well. So that really encouraged us to keep that protocol and apply this to a pilot of 15 subjects who presented with ME/CFS, all female patients, all female because primarily because of the funding source. It was a women's health center who funded this research. We follow the CDC recommended criteria published by the Institute of Medicine. So importantly, I will say we did not expect the patients to have a formal diagnosis, established diagnosis of ME/CFS, because that in itself is a major struggle for many of these subjects. Instead, we just, checked the criteria that they were met for participation, and we examined outcomes in fatigue, obviously, but also brain fog, sleep, mood, and pain. You could say it's not exhaustive. We could have gone on and on and on, but this is what we started. So we anticipated that this group will be very sensitive, particularly sensitive patient group. So we conceptualized the study as two-stage protocol. Stage 1 would really be protocol calibration on 5 patients, just to see how do we need to modify TMS, the standard treatment care, to make it actually tolerable for these very sensitive patients. And I will tell you, the stage 1 seems, this was the major part of a major struggle and the difficulty of this study, even though it's less subjects. And what we found is the following. We needed to reduce the stimulation intensity to make it tolerable and acceptable to these patients. Usually, stimulation intensity is what we call 120% of motor threshold, right? Motor threshold, if you remember, energy needed to elicit finger tapping. Here, we had to go down by 40 or 20%. We confirmed that ITBS was a little more difficult to tolerate, so 10 hertz was better tolerated. We had to switch from ITBS to 10 hertz. We also had to make accommodation for these subjects. We had to limit the commute to 45 minutes max. LA traffic can be terrible, so patients had to either be excluded from the study or they had to make temporary arrangements to live closer to campus for just the duration of the study, because otherwise they would come to the campus and be completely exhausted. Their symptoms would be worse, and that was really counterproductive. So that was, pretty significant. And then once they were on site, we said, why don't we just give you a couple of treatments in a day, like semi-accelerated, so to reduce the total number of visits we have to do per week in total. And I will say that the 3 most significant adjustments was the reduced stimulation, the commute was very significant, and also the number of total visits per week and per course. Now, when we managed to, circle in on that protocol in the second stage, I'm happy to say all 10 subjects were completers. They underwent all 30 sessions, and they also did 2 recordings of EEG. So it was very impressive that we're able to complete the study procedures. And these are the results. You see group level results. In all symptoms, we have a steady and significant decrease for fatigue, mood, pain, sleep, and cognition. Here, cognition goes up because more is actually better, or for all the others, it's, decrease in symptoms. And Here I break it down by response yes or no. So each column is showing one patient and each row is showing one of the symptom domains. Cutoff for response is 30% clinically meaningful, and a cutoff in the literature that is common for mood, because TMS for mood is so established, we were even more rigorous. We had to hit 50% to be considered a response. So you see all the green cells is where there was a response, and gray, there was no response given these cutoffs. So in 8 out of 10 subjects, there was some response in at least one symptom domain, and 7 out of 10 subjects benefited in at least 2 symptom domains. Now, this is obviously not healing ME/CFS. We do not make claims of any that sort, but you know how difficult to treat this condition is. So we were very happy to be at least relieving some symptoms for these patients. I will not, in the interest of time, I will not belabor our EEG outcomes, but I will emphasize this. We did find several correlates of EEG that were indicative of outcome in symptoms, but also severity of symptoms at baseline. And I want to really emphasize this point. There is the patients felt very dismissed and not recognized by the healthcare system. And, hearing anecdotes like, oh, well, I keep hearing from my physicians that I'm just a little bit more tired, and, just not being taken seriously is very frustrating. So when I spoke to the patients about this, saying, look, we actually found some correlates, they were really feeling encouraged and relieved, hoping that the, research like that maybe will support the acceptance of this being an actual, brain-linked condition, and just to have some more recognition from the healthcare professionals. So that is, we can maybe discuss more, but that was really important to our patients. Now, I do have actually 2 bonus slides before wrapping up. You wouldn't believe how many calls I have received from long COVID patients when I was running this ME/CFS study. Obviously, both are systemic conditions, and long COVID is, following a viral infection. A lot of our ME/CFS patients did say that their condition was triggered by an infectious like illness. So there is, actually a good number of studies showing shared symptoms and pathways and even genetic mechanisms. So you could argue, is long COVID a form of ME/CFS? And now that long COVID is so prevalent, it just also enjoys some more visibility. So I had to, due to the funding source of this ME/CFS study, I had to reject all the long COVID patients. And those were a lot. So now we're actually excited to do specifically a long COVID study, still ongoing right now. We are fully booked. We have enrolled all of our patients, but they're still undergoing treatment. So I don't have data just as yet, but they do same protocol, and it's actually a blinded sham control protocol. The first 15 sessions, we have, one group does both sides active, the other group has a motor cortex sham, and then after 15 session, everybody gets active stimulation, and we're also looking at immunological markers. So if that is also positive, then we hope to apply for funding for, large scale study, double blind, looking at both conditions, full treatment course, and we're very optimistic. So to summarize this last part, we were able to apply the same protocol as we did use for MDD and fibromyalgia successfully, but very important modifications needed to be done for the sensitive group. In particular, intensity had to be reduced, and the treatment protocol, as well as flexible treatment schedule, and just reduce the burden really for these subjects. And then we did show there are some physiological correlates of ME/CFS, which will give additional legitimacy to these patients that they really dearly need. Now, to just circle back to our learning goals, I hope next time you think of TMS, remember the wireless charging of your phone. We do say that it's a much more effective approach to treatment if you use a dual target TMS to obtain the synergistic effect and have an integrated kind of approach to treating mood and possibly chronic pain because they're so prevalently observed together. And then TMS for ME/CFS, we really need to be very careful with these subjects. They're very sensitive, so accommodations need to be made to alleviate their burden. On that note, I thank you for your attention. I hope I'm just on time, and I'm looking forward to our discussion, to your questions.
Wow, that was amazing.
Thank
You were
you.
able to explain such a complicated topic in such a clear way that I think will be very helpful to people. I have questions. I can see a bunch of questions coming in the chat. Let's take an 8-minute break. When we come back, we'll do Q&A. Thank you so much. Okay. I'm going to ask a couple questions before we go to the chat. There's some really good questions in the chat as well. So a few people have asked about accessibility. So I did a little bit of research. What I found is there's between 40 and 50 rTMS clinics in Canada, about half of which are publicly funded, basically meaning they're at a university, like in Calgary, it's at the university where they do the rTMS. It's only covered, and I'm sure this is only for treatment-resistant depression, in Quebec, Saskatchewan, Yukon, Alberta, and Nova Scotia. Plus, you can get it at university hospital sites in BC and Ontario. Then the rest, the other 25 or so clinics, are private clinics, and they're mostly in BC, Alberta, and Ontario. So I had one question about the US, whether you know if it's covered by Medicare and Medicaid.
It is. We
Okay,
have Medicare, Medicaid patients. Yes.
that's important because our community, many
Yes.
people are on
Yeah.
disability.
Only for depression, obviously, but it is.
Yeah,
Yeah. I will say in Canada, in Toronto, there is the CAMH, the Center
yeah.
for Addiction Mental Health. It's a major leader in the field, very big center, very prestigious, widely recognized. The data that I have presented about ITBS versus 10 hertz non-inferiority is conducted there. And Calgary is actually the leader in that line of research with respect to the boosting of neuroplasticity with D-cycloserine. So you have some very good TMS research being done in Canada. I mean, you're very
Thank you. And bizarrely enough, just yesterday, I got an email from the University of Calgary saying that they're doing a special rounds next week on Thursday, right before I talked to Dr. Luchter on how TMS works, like at the cellular level. So I'm definitely going to tune into that. One
Yes.
thing with so many private clinics popping up, can you say anything about someone who's looking to go there and potentially pay privately to get it for maybe something other than depression, like maybe someone with fibromyalgia, for example? What should they look for to make sure the clinic is legitimate and they're going to get, an evidence-based treatment?
Yes. I mean, obviously, your FDA indication is the safest way to go, even in the clinical practice, right? But if it's an off-label treatment that you're seeking, the best advice that I can give is to be somewhat educated. I understand it's difficult to read the research articles, but there are like digests and review and meta-analyses. I would make sure that the protocol is being used is evidence-based, right?
Okay.
I'm
Yeah.
saying, that at least a few publications have been do exist on the specific treatment site or treatment protocol, that it's not, completely novel, never heard of, never published. So it doesn't have to be FDA approved to be effective. There is actually a lot of effective off-label treatment. It just so happens that by the time we get an FDA indication, it's years, right? Something like we face right now with ME/CFS. So obviously we do a lot of research, and the indications are just, a little bit behind. So I say evidence-based. You can reach out to an expert. I think people are very, professors and academic centers are very encouraging, and I have responded to so many patients asking me, hey, what is the best protocol? Can I use this and this? And I happily reply and give my opinion. Clinical practice folks have reached out to me, actually, in fact, a lot of times, and say, hey, I have this ME/CFS patient. What can I do? So we share our protocols. And if you're unsure, you can, put us in the middle between you and
Yeah.
the provider, ask for protocol, we can communicate. So I think you have to be a little bit educated about that. Unfortunately, I know it's a lot to ask. However, I will say that we do see that trend in patients more and more. They have shopped around, they know what they want, and say, oh, you know what, I don't want the 10 hertz. Can I do the accelerated thing? And do you do decycloserine to boost? Like, the
Yeah.
patients are increasingly informed. So I encourage you to do the same. There is unfortunately a lot of off-label treatment that is, I think, not evidence-based.
Right.
And
Meaning they're
silly.
they're changing the protocols without doing the research to prove that it's effective.
They're offering a protocol that where there is no evidence or
Yeah.
even a study, not even speaking about FDA indications, not
Yeah.
even sufficient publication on the topic. One area that is, under debate is autism. I think autism is a field where there is a lot of pushback and back and forth. I am not in the field, so I can't really comment on that, but I know there is a debate ongoing. So,
Like whether it's effective or not.
yes, that's
Yeah.
one example. Yeah.
Okay. Thank you.
Mhm.
That's really great advice. So basically, you're saying it's okay to go for off-label as long as the protocol itself has been proven in some studies to be effective.
Correct.
Yeah. I have one other question that's been asked a couple times, and I see who's on the call, and I know it may be on their mind as well. Many people with ME and FM are EMF sensitive, and they're wondering, is
Mhm.
it treatment that requires electricity and magnets going to be accessible for them? Do you have any thoughts or experience on that?
Yes, so valid point. We do induce electromagnetic fields, of course.
Hmm.
Um, However, we have seen a lot of fibromyalgia and ME/CFS patients who have been tolerating the field just fine. Now, I will point out that the electric field is only induced if the magnet is actually on. If you actually hear the pulses, the tap, tap, tap,
Hmm.
tap, tap, that's outside. If it's not exactly currently ongoing, the field is off. So if you just walk into the room with the chair, it's not like there's constantly the field just in the environment the whole time. It really, following the Faraday law, it's only on if there's actually pulse being emitted. So it's a
Hmm.
focused
Okay.
amount of time. It's not the whole time that you're in the clinic. It's really just, the ITBS treatment can be as short as, 5 minutes or so. So
Right.
it is tolerable. We have a lot of patients who have been okay with it. Now, obviously, those patients who might not be tolerable, we might have never seen them in the clinic to begin with,
Right.
right?
They might
They,
not come
they,
show up.
they might
Yeah.
not choose to visit our clinic. I cannot
Yeah.
speak for those, but I would
Okay.
say a lot of patients can handle it just fine.
Fantastic. So we got lots of questions. I'm going to try to be efficient here, and they're all good. Is it still helpful to use rTMS when there's too much activity in certain regions of the brain or just too little? Can you talk about that?
Yes, very good, very complicated question because we need
Yeah.
to understand how TMS actually works, not just, beyond plasticity. And I don't want to make my statement too large, but short answers, yes, because we have seen it's not just augmentation in one area or suppression in the other. We think that in a way, we're giving the brain system a boost to take learning in an easier, faster way. And then it's kind of, it's brain is a surprisingly self-regulating organ. So I'd say we kind of just like supportive function of TMS, and then we're kind of jump starting the process, the healing, getting better process of the brain, and it can calibrate networks that are even downstream beyond the stimulation side. So I will not claim that we have clear understanding of how it really works in the entire brain. I think nobody does, but I will say yes. I encourage you to
Okay,
give it a try.
fantastic.
Mhm.
So here's another good question. Is it part of the protocol to take some kind of brain scan or measurement, such as a QEEG or SPECT scan?
Yes and no. The standard FDA approval is there is no scan, right? So you just
Okay,
come and the coil is placed. It's pretty standard procedure. The SAINT protocol, that is this
right.
accelerated retreat, does require a functional magnetic resonance imaging scan that will use the functional connectivity to individualize your particular target. But that's a very particular protocol. It's not done in most clinics, or only some clinics offer it. So
Mm.
if you don't want it, you can receive treatment without it. If you want to, have it extra personalized, it can be guided by neuroimaging. So both.
And would that be something worth doing? Like, say, because there's another question later on, say you come and you don't get better. Could
Yes,
it be that it's not pointed at the exact right spot and imaging might help?
absolutely. Imaging can help.
Okay.
We also, I didn't speak of that part. You can improve imaging with functional neuroimaging. You can also do EEG guided TMS. There are two particular approaches. You can individualize a specific frequency that where
Wow.
you read out the preferred or resonant frequency of your brain network and try to administer the pulses at exactly that synchronized frequency. Actually, maybe Andy Luchter in your podcast
Yeah.
might talk about this. That's another part of our work that I didn't have a chance to talk about. And there's also, looking at brain state specific stimulation, where we measure your activity in real time and we decide when is the best moment to administer the pulse right then and there.
Wow.
So to hit the right, phase of your activity. So
Right,
so much
right.
going on. 40 minutes would not be enough to
Yeah, yeah, yeah.
Yes,
Yeah,
you
it's a
can
whole
respond.
graduate course.
You can individualize to get better outcomes. Yes.
Um, this person's asking, is TMS compatible with someone who has metal in their
Yes.
mouth, say titanium
Yes.
dental
It
implants?
is. Implants are actually safe. Even
Okay.
anything, uh, actually, even in the cranium, it's pretty safe.
Or say an artificial TMJ
Yes.
joint or something like
Yes,
that.
no problem. We have even treated a handful of individuals with pacemakers. I think the
Mm.
pacemaker is the one thing where we're still most alert. We make sure that we phase the patient in, because we obviously don't want to create any heating or movement or any
Right.
interference. But even that has been safe in our clinic, not the first time that we're doing it. So yes.
Okay.
Mhm.
What about people who are bipolar? Is
Yes.
it safe
Yes.
or indicated? Do you treat just the depression part? Do you treat the mania part?
TMS for bipolar, it's a very active field of research. We don't see a lot of patients. I will say the same protocol as for depression does not work equally well for
Mm.
bipolar depression. So there is
Okay.
a group in Brown University focusing on bipolar and also PTSD. So bipolar, PTSD, I saw there is also a question about anxiety, are
Okay.
conditions where we see some efficacy, but the protocols are still being refined. So yes, possibly.
Okay.
Yeah.
How effective is rTMS for OCD? A great question, maybe in general. You just touched on it briefly, but maybe you could go more. How lasting are the effects? Do people have to come back every year, or, it's
Mhm.
like quite a commitment of time,
Yeah.
right, to come for, say,
Yeah.
36 treatments?
Yes. Yes. So first, OCD in general. OCD has better outcomes with the deep TMS. Not
Ah,
the regular
okay.
figure of eight, but there is a deep TMS coil that looks similar to figure of eight, or the helmet.
Hmm.
The FDA indication for OCD is with the helmet. And there, the follow-up, I think, is usually ending at 3 or 6 months. And so they have shown efficacy at that, those follow-up time points for OCD, but it is also more difficult to treat than just regular depression. And often we have MDD plus OCD comorbid conditions, right?
Right.
So longevity or durability of effects vary quite substantially patient by patient, and we don't know yet why. Some patients might have an effect, for a month or two. Some others do not return to the clinic until several years later. So it can be really
Wow.
2 months to 2 or more years. And we actually don't know yet why and how to better, improve longevity or durability of effects.
And are there any problems getting it covered? Say you're someone who you lose the effect after 2 to 3 months. Will insurance pay for you to come back every 3 months for another round?
Yes, I think that depends on the insurance, but we have
Okay.
participants or actually patients who are able to receive repeated courses of TMS, especially if the first course was successful. Then insurance is I'm not sure if they're required, but often they are reimbursing
Okay.
in third course.
This is a great question. And I'm so curious to learn more about the neuroplasticity aspect. But this question is about whether there's research being done in people who have dementia. And
Yes.
it's like, oh, wow, well, if you're able to activate the neurons, maybe this could really
Yes,
shift
there
things.
is research. Actually, in our group, there are two studies. One study is on mild cognitive impairment, right? The early
Mhm.
stage of dementia, and also most recently, Alzheimer's disease proper. And both studies target different areas of the brain, not the left DLPFC, but they are focusing. So this is where we need the brain scan because we want to target an area. I mean, obviously, memory function. We know that the hippocampus, right, is sitting deep in the brain, very difficult to access with TMS because TMS, it's a couple of centimeters deep, but we
Mhm.
don't think we can reach all the way to the inner structures. So here we rely on the scan and we try to target an area on the cortex that is strongly connected to the hippocampus. So we kind of through the proxy, like through the entry portal, reach the hippocampus indirectly. So we target the posterior parietal cortex for MCI and the precuneus for Alzheimer's. And both studies are still blinded. And
Okay, so you don't know your results yet.
this is not a lot of groups do that, but I think in the next couple of years, there will be a plethora of studies being published. So stay tuned.
Okay, that's really encouraging. This is another great question, whether in some people the responses can be delayed. So I remember when I referred patients to rTMS, I would inevitably get a phone call. I've been going for 2 to 3 weeks. I'm not really sure yet if I'm noticing anything. I would always say, like, go for the entire course, but you're much more experienced than me. So I get a sense that it kind of accumulates,
Yes.
and it's more closer to the end that you start noticing benefit. Is that correct?
That is correct. So for regular treatment, I will say so it's 6 weeks. Within 2 weeks, so after 10 sessions, if
Hmm.
you have not received at least some benefit, it's
Hmm.
unlikely you're going to benefit even 6 weeks later or
Oh,
months
okay.
later. So 2-week outcome after 10 session is a very strong clinical predictor of final outcome. So we know pretty early on. However, everything is different for accelerated protocols. I think the question in the chat was
Oh,
several twice a day treatment, right? So it's kind of somewhat accelerated. And
okay.
those protocols have a different timeline of response. We see not uncommonly that the brain is kind of behind. You plug in so many sessions, like two sessions a day, three sessions a day. The accelerated sane protocol is 10 sessions a day for 5 days. So the brain needs time to actually, physiologically change. And that is a slower time scale. So we often see patients getting better 2 weeks or even 4 weeks starting to see improvements. So that
Okay.
whole accelerated treatment, I think, hang in there, finish the treatment, and it's don't break off the treatment prematurely. For the classical course, I would still finish the treatment, especially if there are no side effects, but the 2 week prediction, 2 week outcome is a predictor. What we do, and I will just say that we do at UCLA something what we call measurement-based treatment. So after 2 weeks, we measure your outcome, and if you don't show that minimal improvement, we try to augment your regular FDA-approved treatment with something extra, and that can be off-label, so you get the
Yeah.
FDA-approved plus a booster, and we can get you more better with that booster. So there are different ways.
That individualization. So I guess, I'm going to add to your answer. If people are looking for a place, you want to go to a clinic where they've really been doing it for a while,
Yeah,
because that will allow them to have the confidence to add those boosters and
correct.
to change in the midst of a
Yes,
course if they can see things aren't quite working.
correct.
Yeah. I just want to say we have a survey.
Mhm.
Megan is going to post it again. So the survey is asking you very, very short 4 questions. How did you like this talk? And do you like this kind of science presentation? So especially if you're new to my events, please fill out the survey. Literally, it will take you 2 minutes or less, just to give me feedback so that I know what kind of speakers you want to have in the future. Someone's asking, can you use rTMS to go off medication?
Yes, you can. I mean, I have seen patients. We usually, when patients come in seeking treatment, we try not to remove any medication, just keep everything
Yeah.
stable. However, if the treatment course was successful, in communication with the primary psychiatrist, you can have a conversation between the TMS physician and your treating psychiatrist to slowly ramp down or completely remove. But, caution is obviously recommended. But yeah, I have seen successful cases. Yes.
I just want to really support what you just said about slowly. So, in my experience, if people are on a drug they don't like causing side effects, they tend to go off cold turkey.
Yeah.
And with antidepressants, as many of you know, that there's rebound and discontinuation effects that can be pretty unpleasant. So,
Yeah.
really support Dr. Corlier in the slowly.
Yeah.
Um, so someone's asking about clinical treatment in Canada. So it's here. It's been here for several years, especially if you live in a city with a university center, say like Toronto, Calgary, Vancouver, probably Edmonton, maybe Halifax. I don't know all the centers. It is available, and like my research suggests that there's maybe 20, 25 private clinics. I know there's at least one in Calgary as well. The downside of the private clinic is you have to pay, whereas in Canada, of course, if you go through one of the university centers, it will be fully covered. Someone's asking how to find a center. Do you know, is there any directory or no?
Uh, I'm not aware of like inventory list of TMS clinics.
Okay.
No,
Just
ask.
have to Google search where you
Yeah,
live.
I think so. Yeah.
Okay. We're getting to that anxiety question. So anxiety and depression so
Very.
often occur together. Does it
Yes.
impact the anxiety as well?
So I will say that anxiety response is more treatment resistant than the classical depression
Okay.
symptomatology. We do treat anxious depression with some success, um, but I think there are also currently uh, specifically designed protocols under investigation that are targeting that
Mm.
anxious profile. In particular, again, there's so much research to cover. Within depression, you can have subtypes. Not all depression is the same. Two different people
Mm.
might have, more anhedonia or more anxiety or more insomnia. So a novel approach is actually go by symptom profile. So
Mhm.
again, that would be that has been based on neuroimaging. You might have to do a neuroimaging scan, but we might be able to individualize a different region, brain region for stimulation to target more like the anxiety circuit.
Okay. So
So
in progress, we'll say.
in progress, but
Yeah.
hopeful.
Does treatment work for the elderly? So someone who's in their 80s?
Yes, it has. We have published that actually elderly might benefit even more than
Wow,
junior folks. So please, if you're interested, seek out a center.
that's very
Ah,
encouraging. For the long COVID study happening currently, are you using the protocols you established for the ME/CFS group, i.e., lower
correct. Correct.
strength, fewer
That
sessions?
correct.
Yeah.
That modified protocol because
Okay.
we do see that patient groups are have similar burdens and struggles. So we took that gentle TMS gentle approach and accommodating schedule and intensity. Yes.
Okay. Um, So I'll maybe try this one because you're not from Canada. So for treatment centers in Canada, are they regulated? So most of them, at least half, are in university centers. So I think you can rest assured they're regulated. There's so many layers of bureaucracy kind of overseeing that. If you're considering a private clinic, they still need to be approved. So in every province, there's a College of Physicians and Surgeons. Those colleges um, like when I was running my red light laser machine here, I had to have it like not investigated, but I had to prove to the college that the machine was legitimate, that it had passed all of its tests, that it was what it said it was supposed to do. I had to send them a bunch of paperwork. I'm sure that's the same for any rTMS clinic. So you could ask the clinic to see their college certification. And if they won't show it to you, then I would say that would be a red flag. Someone's asking, do you see vision side effects? So someone was
I saw,
enrolled in
yeah,
a
I saw that
study.
question. I
Okay.
I have seen one patient, it was actually an MCFS patient who have complained about blurriness of vision. And I offered, we took that seriously. We made a note, we reported it. And this patient benefited so much, she did not want to stop the treatment and continued until the very end of 30 sessions. And then she reported afterwards as a follow-up that her vision did get better. Now, we do not know if the TMS somehow aggravated the side effect, but she did report blurriness in her vision during the session and between the sessions. But she took that, she
She
continued.
still
That was
benefited.
one patient that I
Yeah.
personally have seen.
And what about, so this question's also asking if someone has retinal damage already, would that put them at any different
That
risk?
that was the case with that patient. I think
Okay.
she had some retinal precondition, so it was very similar situation. Yeah.
Okay. Here's one new question. Is there any research on rTMS and ADHD?
Yes, there is. I think inconclusive, there's a lot of research. Obviously we are targeting brain fog. We are hoping to enhance cognitive function. So why not ADHD? But again, it's in its early stages.
Okay. I think our last, maybe two last questions. One is, I'm assuming the answer is yes, because it's approved by the European, I don't know the name of the European Health Commission, but are there centers like these in Europe?
Yes, there are. There's a lot of research. There are clinical practices. I know that the Europeans are a little bit more conservative about TMS. I know in France
Oh,
there's been a
okay.
major pushback even for depression, but I have a close colleague in France who's doing a lot of the TMS for pain research. So TMS in Europe does exist. I'm not sure how, maybe it's not quite as popular and maybe not as
Okay.
reimbursed as in the US, but
Okay.
it is a thing there as well. So I would,
And then
yeah.
Yeah, the last question, I just want to say thank you. This was really practical and clear and useful. And so the
Pleasure.
last question is, where could doctors reach you if they wanted to make sure that they know the kind of adapted ME protocol?
Yes, please email me. We have, I think the email is best place to
Okay,
reach me. We have also, this is our website. You can also um, look more at our profiles of the physicians, reach out to one of the physicians, but anything off-label, the physicians might not know, as much as the actual researchers doing the protocols.
right.
Please feel free, and I dispatch to if I need additional input from the doctors. Okay, so happy
Thank you.
to meet.
Yeah.
Mhm.
What we'll do, Dr. Corlier, is we'll maybe attach maybe the website, maybe not your personal email, but maybe the website with the recording, and then
Ah,
people can contact you that way.
perfect.
Thank you
Happy
so
looking
much.
forward to your correspondence. Thank you
Okay.
for having me. It was great. My pleasure. Thank you so much.
Okay. Bye, everybody.
Bye, everyone.